So good morning everyone. Today we continue our journal club presentation with Dr. Mahmoud. He will talk to us about a very common topic that we need to know about a lot because we see a lot of cases, and that's ultrasonography of the scrotum in adults. Follow.
Okay, good morning everyone. Today's topic will be about ultrasonography of scrotum in adults, which is prepared by me and supervised by Dr. Ahmed D. So let's start with some anatomy just to be oriented. The normal male testicle is an ovoid structure measuring approximately about 5 by 3 by 2 cm in dimensions, with a homogeneous intermediate echogenicity, and the epididymus is a comma-shaped elongate structure which is located which is divided into 3 parts: epididymal head, body, and tail. The head is overlies the superior part of the testicle, while the body and tail are on the posterior medial part of the testicle. So they are located behind and at the inferior pole of the testicle. The tunica albuginea is covered by the tunica vaginalis, a remnant of processus vaginalis, which represent a closed sac of peritoneum, and the processus vaginalis is composed of 2 layers, visceral and parietal layers. The parietal layer lines the inner surface of the scrotum. The parietal layer.
The parietal, the scrotum, yes.
The scrotum, and the visceral layer covers the tunica albuginea and the testicle. And they are these 2 layers of tunica vaginalis are separated by a minimal amount of fluid, which is normally present and should not be confused with hydrocele. It's normally present, and the tunica albuginea extends into the posterior medial testis to form the rete testis, or what's called mediastinal testis. The rete testis, which contains ducts, nerves, and blood vessels. The mediastinum is usually seen on ultrasonography as a thin echogenic band. There are several fibrous septa that extend from the mediastinum testis to divide the testicle into small lobules, which are multiple and diffuse. These lobules contain seminiferous tubules which converge to form the tubuli recti, which is the testicular ducts that open into the rete testis. Efferent ductules exit the rete testis and drain into the epididymal head. From the epididymal head, the ducts are converged to form a main duct which traverses the epididymal body and then tail, which then emerge as vas deferens, and the vas deferens continues upward through the spermatic cord and continue until it unites with seminal vesicle to form the ejaculatory duct. The spermatic cord, in addition to vas deferens, contains vascular supply and lymphatics, nerves, also the pampiniform venous plexus. The spermatic cord also appears as a highly echogenic band within the inguinal canal. The blood supply of testicles are from the testicular arteries, which are branched from the aorta, and the venous drainage from pampiniform venous plexus will drain at the left side to the left renal artery and then to the IVC, while right side directly to the IVC. We have epididymal and testicular appendage, which represent the embryologic remnants that can be identified on ultrasonography, especially when there are associated hydroceles. The appendix testis, or what's called hydatid of Morgagni, is seen as an isoechoic oval structure located between the epididymis and the testis, while the appendix of the epididymis is an pedunculated structure arising from the epididymal head, which also appear isoechoic to the testicular tissue. So regarding the scan, the preparation of scan, only the area of interest should be uncovered. We should place a towel beneath the scrotum and testis to elevate it, and another towel in patient's hand which to retract and cover the penis. So starting the pathologies, we have acute scrotal pain and swelling, starting with epididymitis, which is a common cause of scrotal pain in adolescent boys and male adults, which is epididymitis, which is usually the result of acute bacterial infection. Extension of infection from the epididymitis to the testicle sometimes occurs, mostly occurs, they are mostly together and called epididymo-orchitis due to direct invasion or spread of infection to the testicle. Ultrasonographic findings of acute infection of the epididymis include enlarged hypervascular epididymis with an inhomogeneous ecotexture, most often hypoechoic in appearance. Color Doppler ultrasonography evaluation has a sensitivity of almost 100% in detecting acute inflammation and is thus a well-established imaging technique for diagnosis of epididymitis. Associated findings include hydrocele or sometimes pyocele, scrotal wall thickening, and in advanced or neglected cases, let's say, fistula formation and calcifications. Sometimes hypoechoic areas are seen which are avascular and irregular outline suggesting abscess formation. Next one is orchitis. As we said, isolated orchitis is less common than epididymo-orchitis. They are present together, and orchitis alone is rare and most commonly secondary to paramyxovirus infection, what's called mumps. Orchitis most often appears as diffuse testicular involvement. However, it may only involve a focal area. And clinically, orchitis present with only mild tenderness. Sometimes the patient is febrile in advanced cases. And ultrasonographic features include enlargement of the testicle, hypervascular, homogeneous ecotexture, and increased, as we said, increased vascular flow is sensitive for this pathology. And there is diffuse and focal types. In cases of focal type, we should have care about other pathologies. For example, tumor or infarction or metastasis. So in the cases of focal orchitis, follow-up should be recommended to differentiate between the pathologies. Regarding torsion, testicular torsion is most commonly seen in adolescent boys, though it can occur at any age group. Normally, the tunica vaginalis fixates the posterior aspect of the testicle. Sometimes the tunica vaginalis joins the spermatic cord high, leaving the testicle rotate freely within the scrotum. This deformity is called bell clapper deformity, which is most commonly found bilaterally. So when the orchidopexy done for torsion, it is done bilaterally, even if there was unilateral torsion. A sensitive and specific sign for torsion is what's called whirlpool sign, which is characterized by spiral twisting and rotation of spermatic cord. Following the rotation, the blood supply will diminish, and at early stage there will be only venous supply compromise and the testicles appear normal. While in later stages, the arteries are affected as well. So there will be other findings like enlargement, heterogeneous appearance of the testicle, and in neglected cases there will be areas of necrosis and altered blood flow. And we have incomplete torsion and complete torsion. Complete torsion, there is complete absence of blood flow in both testes and epididymus, while in incomplete torsion, there is some flow, while there will be elevated resistive index, and there will be, the waveform will be to and fro flow, as there's an image of the waveform. As we said, at neglected late cases, there will be enlargement, heterogeneity of the testicle due to edema and arterial obstruction. Definitive diagnosis of complete testicular torsion is made when color Doppler fails to detect any blood flow within the testis and the epididymis. This is the whirlpool sign, as there is twisting of the spermatic cord. This is another case which there's missed or late testicular torsion, as you see areas of necrosis and heterogeneity occupying the whole testicular parenchyma, and no vascular supply within the testicular parenchyma, but there will be presence of collaterals at late stage after few days, and enlargement of small peripheral collaterals will be seen on color Doppler. The importance of diagnosis in early stage is to not to miss the case, and there will be 100% success rate if performed, the surgical intervention performed within 6 hours of symptom onset, while the success rate will be decreased to 20% to 0% if symptoms have been present for 12 to 24 hours. Sometimes there are cases of intermittent testicular torsion, which should be considered in patients presenting with recurrent acute pain and resolution of pain. At these cases, also surgery should be indicated in order to relieve pain and prevent further infarction of the testicle. We have cellulitis of the scrotal wall, which is an acute inflammatory scrotal wall edema, and often seen in patients with diabetes, obese, and immunocompromised patients. The ultrasonographic features include increased thickness of scrotal wall and hypoechoic with increased vascular flow. At late cases, there will be hypoechoic areas, irregular outline with increased surrounding vascular flow, suggesting abscess formation containing fine low-level internal echoes. As you see, there is marked diffuse thickening of the scrotal wall, loculated hypoechoic collection, increased vascularity, surrounding vascularities, developing abscess. Regarding trauma to the scrotum, can manifest as fluid collection or testicular disruption and vascular injury. Ultrasonographic evaluation of an injured testicle is crucial as it requires immediate surgical intervention. Ultrasonographic findings include heterogeneous appearance of the testicle, irregular contour, abnormality with or without interruption of tunica albuginea, as it is seen on the image, and loss of focal or diffuse vascular flow. The signs are consistent with testicular rupture or laceration. This is another example of post-traumatic testis, as the left testicle, this the ultrasonography of left testicle, demonstrates heterogeneous ecotexture with irregular contour and are associated complex left side hydrocele and hematoma formation, capsular rupture. The findings are consistent with post-traumatic testicle. Regarding palpable lumps and incidental findings, we have the most common one is epididymal cyst. Can occur anywhere in the epididymus, but mostly in the epididymal head, which appear as a well-defined anechoic cystic lesion with posterior acoustic enhancement due to the serous fluid content. It has no clinical significance unless it's large and symptomatic. We have epidermoid cyst, which is often present as a non-tender small testicular nodule. They represent the most common benign testicular masses and have no malignant potential. They are referred as keratocysts because they contain keratin content, and the keratin content often makes the lesion appear solid, and they appear in many ultrasonographic appearances, but the classical one is what's called onion ring skin pattern, lamellated, and there are lamellated and hyperechoic and hypoechoic layers. The hyperechoic is the keratin, and hypoechoic is the fluid, which is cystic. This appearance grossly corresponds to the multiple intraluminal layers of keratin within the cyst. Despite being a benign lesion, epidermoid cysts can often not be distinguished from malignant neoplasms like teratomas, which may present with similar ultrasonographic appearances. So in the presence of when there is no internal vascularity and negative tumor markers, testicular enucleation can be done rather than orchidectomy. We have spermatoceles, which they are rarer than epididymal cysts, but they have almost same ultrasonographic appearances, except that they are larger and may present as multilocular cysts with internal echoes, which may be related to the proteinaceous materials and spermatozoa. Some literatures report as higher incidence of spermatocele in patients underwent vasectomy, while the epididymal cysts occur in in general population. We have varicocele. Varicocele is an abnormal enlargement of the pampiniform venous plexus in the scrotum. It's common and occurs in 15% of adult men, making it the most common palpable masses of the spermatic cord, which is due to impaired drainage of blood from the spermatic cord, causing abnormal dilatation of pampiniform venous plexus. Cases of idiopathic varicocele are simply caused by incompetent venous valves, while there are also secondary causes due to extratesticular problems like cirrhosis, hydronephrosis, or abdominal and pelvic malignancies. Clinically, by palpation of the scrotum, it may reveal as a mass, often described as a bag of worm, and by ultrasound shows multiple hypoechoic or anechoic tubular structure greater than 2 to 3 millimeter in diameter. Occasionally, low-level echoes are detected within the lumens, which represent the slow flow of blood within the lumen. Few important points about varicocele for clinical practice. Varicoceles are most commonly found on the left side. If a newly diagnosed unilateral right side varicocele seen, it should be of concern, as there will be a pelvic or abdominal malignancy.
Especially if the varicocele on the right present, on the
Yes.
left not present.
Yes,
If on the
unilateral.
left present, right normal, that's okay.
That's okay, yes.
But if on right present, left not normal, then you look for
Suspicious.
some malignancy
Another
or something in the pelvis.
We have also nutcracker syndrome, which is also a venous compression disorder in which the abdominal aorta or superior mesenteric artery makes compression on left testicular vein and increased pressure transmitted into the pampiniform plexus as well. We have gradings. The most common and well-known grading is Sartikis classification, which has 5 grades. The first grade, the reflux is seen at the level of groin only during the Valsalva maneuver. Grade 2, the reflux is seen at the level of proximal pampiniform venous plexus, only during Valsalva. Grade 3, at the distal part of the lower scrotum, and only during the Valsalva maneuver. These 3 grades are not associated with scrotal deformity or testicular hypertrophy, while in grade 4 we have spontaneous reverse or reflux, which increase during Valsalva maneuver with scrotal deformity and possible testicular hypertrophy. Grade 5, we have resting reflux in pampiniform venous plexus and increasing during Valsalva maneuver and always accompanied by testicular hypertrophy. This is another grading based on size. We have 3 grades. Grade 1, the mean diameter is 3 to 4 millimeter in relaxed standing position and 1 millimeter increase on Valsalva maneuver. Grade 2, moderate diameters, 4 to 5 millimeter in relaxed standing position, and there is 1 to 1.5 millimeter increase on Valsalva maneuver. Grade 3, we have large varicocele, the mean diameter more than 5 millimeter in relaxed standing position, and more than 1.5 millimeter increase on Valsalva maneuver. Regarding hydrocele,
About the size. It's fine position.
We will comment on it later.
Hydrocele is a large fluid collection between visceral and parietal layers of tunica vaginalis and is the most common cause of painless scrotal swelling. As we mentioned, there is normally some serous fluid content at this space, which should not be confused with hydrocele. And it can be congenital or acquired. Congenital due to post-processus vaginalis, in which the peritoneal fluid remains within the scrotal sac and accumulate there. And acquired hydroceles are either idiopathic due to overproduction or decreased absorption of serous fluid, and there may be secondary due to infection or torsion, trauma, or tumors. Ultrasonographic features include anechoic fluid collection with increased through transmission that surround the anterolateral aspect of testis. Internal echoes may also present, which may be related to protein and cholesterol contents. We have microlithiasis. Microlithiasis are microcalcifications. They are incidentally found and seen about 5% of males between the age of 17 and 35 years. There are microcalcifications of 2 to 3 millimeter in size with multiple non-shadowing. And if there was 5 or more microcalcifications within a single field or transducer field, should be taken as serious condition. And microlithiasis is regarded as a premalignant condition or causative agent. Patients diagnosed incidentally with microlithiasis should be advised to do annual screening, ultrasonographic screening, especially when they are symptomatic. This is a grading according to studies regarding the severity. We have 3 grades according to the number of microcalcifications within a single transducer view. If there are less than 10 microcalcifications or microlithiasis, it's grade 1. If 10 to 20, grade 2. If more than 20, it is grade 3, as the risk will increase by increasing the numbers. We have scrotal leaf, or sometimes called scrotal peels or scrotal calculi, which are mobile calcifications in the scrotum and represent calcified loose bodies that result from torsion of the appendix of testes or epididymus, or reactive fibrous proliferation of intrascrotal inflammations. On ultrasonography, they appear as free-floating echogenic foci measuring up to 10 mm with posterior acoustic shadowing and are located outside the testicle. And about half of cases are present with associated hydrocele, which facilitates easy detection, and they have no clinical significance. We have adenomatoid tumor, which is a benign neoplasm that most commonly arises from the epididymal tail, accounting for approximately 30% of extra-testicular tumors. It is most common solid neoplasm of the epididymus, and ultrasonography assessment reveals a well-circumscribed hypoechoic rounded mass with a usually homogeneous ecotexture. Because the ultrasonographic appearance can vary, the tumor is often resected. There are no current documented studies or cases of recurrence or metastasis after excision. This is another case, a 39-year-old patient with palpable mass on left testicle and pain for over 2 years, preceding over 3 months, last 3 months. Physical examination revealed a 2 cm hard, tender, non-mobile, non-separable mass in the upper pole of the testicle. On ultrasound, a 30 mm well-defined hypoechoic mass seen at the left pole of the testicle with limited vascularity, confirmed by histopathology to be adenomatoid tumor.
Which is weird because usually it's in the epididymus.
It is located at the upper pole. I put this case because it was different than normal cases. Testicular tumors. Testicular tumors are divided into 2 main categories, germ cell tumor and non-germ cell tumor. Germ cell tumor accounts for 95% of testicular tumors, and non-germ cell tumor only 5%. Germ cell tumor divided into seminomatous and non-seminomatous tumors, and non-germ cell tumor to 6 cord stromal tumors and others like metastasis or lymphoma. Seminomas are the most common testicular malignancies, account for 35 to 50% of all cases. Because of their high sensitivity and for chemotherapy and radiotherapy, they have a very good prognosis. On ultrasonography, seminomas appear as hypoechoic, well-defined lesions with internal vascularity, which can range from small to very large masses that replace the entire testicle. Non-seminomatous germ cell tumor present ultrasonographically as heterogeneous and cystic masses with echogenic foci, which may be calcifications, fibrosis, or hemorrhages. There is sometimes there may be increased vascularity, mimicking acute testicular inflammation, especially focal types. However, the testicular underlying testicular parenchyma are inhomogeneous in appearance rather than a regular ecotexture. So at these cases, follow-up ultrasound should be recommended to to differentiate between inflammation or space occupying lesion. As you see, there's a case, mixed germ cell tumor, with 99% of embryonal carcinoma and 1% seminoma. It is confirmed by histopathology. This is another case, as you see, an ill-defined heterogeneous hypoechoic lesion with internal vascularity, diagnosis made by histopathology to be mixed germ cell tumor. We have non-germ cell tumor. At this group, 6-cord stromal tumors account for the majority of non-germ cell tumors. These tumors are benign in about 90% of cases and usually found incidentally due to their small size, and frequently encountered non-germ cell tumors are Sertoli cell tumors and Leydig cell tumors. There are some rarer cases like granulosa cell tumor and fibromatomas and mixed 6-cord stromal tumors. These tumors do not exhibit specific ultrasonographic characteristics but appear as well-defined hypoechoic lesions. Regarding these findings, the cases mostly undergo orchidectomy. This is another case of a well-defined hypoechoic lesion confirmed to be lymphoma by histopathology. Lastly, I put these two cases just to give the idea. The ultrasound is not the only modality to reach the final diagnosis. As you see, these two cases, the only difference is echogenicity and the size. At the upper one, hypoechoic, while the lower one is isoechoic to the normal testicular parenchyma. But the histopathology reached the diagnosis as seminoma and non-seminomatous tumor. Thank you.
Thank you very much. Good overall coverage of the topic. For me personally, I have few comments. Keep in mind. خصوصا للfemales, any acute scrotal pain is a suspected torsion. Acute يعني up to 6 hours, few hours. Okay? So when it's torsion, you should do an ultrasound because you have 6 hours to save an organ. After 6 hours, bye-bye. It's gone. Called the golden 6 hours. Okay? If the patient says, I had pain for a few hours and now it's gone. راح البين. It's infarcted. هو المريض فرحان انه راح الوجع. لا مو راح. هو infarction. خلاص. باي باي تستيكل. اوكي؟ يعني إذا يقول راح خلاص it makes اروح للبيت وباكر اسوي هو infarcted. بس if it is not resolved لا هسه تجي هسه قبل لا يصير infarction to save what's possible.
Ischemia, pain.
Okay, ischemia pain, infarction no pain, infarction dead. هاي أول شغلة. شغلة ثانية torsion. The first thing to go is the venous flow. يعني أول شيء يروح يتأثر هو الفينوس. الارتريال يظل بعدين يروح الارتريال. أول شيء الفينوس. يعني if you see intra-testicular shot intra مو extra داخل التستيكل. If you see venous flow, this is not torsion. venous خطين جوا venous. شفت venous flow ما شفت arterial مو مشكلة. يجوز الدوبلر مالتك بإشكالية. بس when you see venous flow, this is not torsion. If you don't see venous flow, maybe torsion, maybe not. You go for arterial. You look for arterial. If you see arterial, you exclude torsion, but you cannot exclude torsion, detorsion. ممكن هاي testicle torsion وdetorsion, torsion وdetorsion. So you're right. Intra-testicular arterial flow is seen. possibility of torsion detorsion should or cannot be excluded. يعني ممكن يكون يمك صار detorsion يطلع المريض يروح البيت يرجع يصير torsion. It's mobile. اوكي؟ هاي شغلة ثانية. الشغلة اللي يعني for my personal opinion, any acute scrotal pain should be considered torsion until proven otherwise. So راح يصيحوك راح تسوي ultrasound. If it was positive for torsion, if this torsion, he will go to surgery. If it was negative for torsion, you cannot exclude torsion detorsion. He will go for surgery. ما تروح للسيرجري بعد ليش جاي؟
الديفرنشال يعني
ما ماكو you cannot exclude torsion detorsion. إذا عنده torsion راح يفوت سيرجري. ما عنده torsion you cannot exclude torsion detortion. هم راح يروح سيرجري.
لا ما يروح يطلع على مسؤولية.
هاي ما لي علاقة أنا أحكي لك الميديكال بارت السوشيال
ما يسوون
هذا
ما يسوون.
يوم.
أنا ما يسوون اوبريشن
لا أقول لك أنا أحكي لك الميديكال بارت وليس السوشيال بارت. أوكي هاي شغلة. الشغلة الثالثة واللي لازم الكل ميلز وفيميلز ينتبهوا لها في حالات السسبكتد testicular trauma. Your target is بس خليني سوري طلع لنا فد واحدة من الصور تكون واحدة من الشغلات أو مش أهم شغلة لازم وين كانت مال الهيدروسيل هاي suspected testicular trauma. أنت شو تدور؟ ما لك علاقة بالهيدروسيل والمدري شنو هذه. أنت تدور تونيكا البوجينيا هذا الخط تشوفه this line pointed أحسن.
There was a case to ruptured.
أي this line you have to see it all over the testicle. If it's not continuous or you find an area that this thin line is interrupted, this is testicular rupture. حتى لو testicle still intact to oval shaped وكذا إذا هذا الثين line التونيكا is interrupted يروح surgery. تمام؟ هاي الشغلة الثانية. الشغلة الثالثة regarding الvaricocele. It is recommended that we do it in standing position. Recommended. I know most of us, and maybe all of us, we do it in supine position. But I've seen a lot few cases اللي بالسupine يكونوا normal. بالstanding position, grade 3. I've seen a few cases. So, the recommendation is to do it in erect position, in standing position. Okay? But say for difficulties in positioning the patient, most of us we do it in supine position. So if there is a high suspicion of varicocele and you see nothing, tell him to stand up. Okay? Then, any comment, any question, any?
Varicocele, it's happen in children,
Very rarely. Very rarely. Very rarely. It happens, but very rarely. يعني usually you see it after 16, 17 years of age. يعني usually. Keep in mind إذا تشوف testicular microlithiasis or testicular microcalcification, high risk for seminoma. You recommend annual or biannual ultrasonography لأنهم راح يصيرون عندهم seminoma هواي. الريكومنديشن once annually. بس يعني خلي يسوي بالضبط human markers ومثلا يعني ممكن once a year, twice a year ultrasound. It's nothing big يعني. You patient can do it. Okay. بعد.
إذا بالسباين varicocele size بالdiameter شلون يعني يسوي classification؟
حسب الجريدنج اللي طار فيه.
هاي كان standing نفس السباين؟
نفس. هو it's dilated veins. Whether it's in standing or in supine, المهم إنه veins dilated, so it will make blood flow slower, and it make the testicle warmer, gets more hot, and this will decrease spermatogenesis, can cause some sort of infertility or
I
subfertility.
mean the grading by diameter.
نفس الشيء.
3, 4,
جريدنج
5
باي
more than
دايمتر
5.
من وين جبت؟
Well, for me personally, I don't agree with this grading, but
Doctor, Starting's classification is most dependable
Most, yes.
one, but they اكو physicians depends on
Yeah, definitely. Okay, thank you very much.
كله معناه